Well, here we are, National Thrombosis Week, and thank you everyone for joining in this session organized by Thrombosis UK on innovative care models for anticoagulation and VTE care. We are fortunate to have three brilliant speakers and three brilliant topics. The first speaker is going to be Rosalind Byrne, who's lead pharmacist for anticoagulation at King's College Hospital in London. So please, everyone, do make the most of this learning opportunity and submit your questions via the Q&A preferably, or via the chat tabs. So welcome, Ros, over to you. The topic is anticoagulation stewardship.
Hi, everyone. I hope you can hear me. Apologies, I have a bit of a cold, so my voice is a bit strange. So I'm going to talk about anticoagulation stewardship. So firstly, what is anticoagulation stewardship? So in 2022, the National Quality Forum and the Anticoagulation Forum in the US published this document. It was called Advancing Anticoagulation Stewardship, a Playbook, and it set out core elements. It defines anticoagulation stewardship as a coordinated, efficient, and sustainable initiative designed to achieve optimal anticoagulation-related healthcare outcomes and to minimize avoidable adverse drug reactions. So using evidence-based care, appropriate prescribing and dispensing and admin of anticoagulants, and appropriate patient monitoring. It's quite a hot topic, and I've had quite a few inquiries from pharmacists as far as Australia wanting to come and visit us to see how we do anticoag stewardship, essentially. I think for us, it's not a groundbreaking concept because in terms of the function of our anticoagulation services, the basis of our services are anticoagulation stewardship. And my job as lead pharmacist for anticoagulation is basically putting in place anticoagulation stewardship. So where specialist anticoagulation service exists, this is basically what we're doing. However, this document is really useful. It provides a useful reference for improving anticoagulation safety, and there's loads of tools and resources within the document to help facilitate anticoagulation stewardship and introduce it where services aren't there or where they're not quite adequate. So it builds on the concept of antibiotic stewardship, which has been around for about the last 25 years. And in the US has resulted in a reduction in ED visits for antibiotic-associated adverse drug events. Anticoagulation stewardship on all these stewardship programs are a holistic approach which span the continuum of care. In 2023, though, a meta-analysis was published from Cork University Hospital looking at anticoagulation stewardship programs and using the Anticoagulation Forum document and looking at the core elements, which I will go through shortly. But they found that interventions that had been put in place around anticoagulation stewardship included education to healthcare professionals and patients, medication reviews, implementing guidelines and protocols, and interventions to facilitate transitions of care, amongst other interventions. And they showed observed clinical benefits in terms of increase in safe use of anticoagulation and cost savings from that meta-analysis. So why do we need anticoagulation stewardship? Well, we know that anticoagulants have consistently been identified as the most common cause of ADs across various healthcare settings. In the Anticoagulation Forum document, they highlight a few reasons why this is, and one of them is obviously the side effect profile, the narrow therapeutic window of the vitamin K antagonists, some off-label uses of DOACs in terms of indication and dosing, lack of familiarity with DOACs, I guess, sometimes confusion. I certainly know that this has happened in our institution in terms of confusing peri-procedural guidelines for vitamin K antagonists with DOACs, and then conflicting information around drug interactions with DOACs. So the document comes up with the core elements of anticoagulation stewardship, and the first one is leadership and professional accountability. And it's really a way of giving a guideline on how to start these anticoagulation stewardship programs. So the things that usually make these kind of programs work, including key stakeholders, using data and experience from existing successful programs, and there's loads of information about existing programs, some of which I will talk about shortly. aligning with organisational priorities and sharing cases of patient harm to give the case for the need for anticoagulation stewardship, and then to identify gaps in the current programmes. Anticoagulation, like antimicrobials, is a subject area or a clinical area that spans all other disciplines, really. And so it's really important to include the multidisciplinary team in all aspects of patient care and in all of these stewardship programmes, and to use cross-departmental collaboration. So in terms of reducing inappropriate bridging with DOACs, for instance, we collaborate with our surgical colleagues. The use of data collection and analysis is another core element. So strong anticoagulation related data collection, analyze processes to identify gaps and evaluate priorities, and implement quality improvement strategies by creating data collection tools, developing informative performance reports and dashboards to support decision making. Another core element is systematic care, safety and quality. So using creation of anticoagulation related policies, procedures and order sets, establishing clinical decision-making support and risk assessment tools, and promoting protocols and guidelines. And on the website for the Anticoagulation Forum and in this document, there's a list of, I guess, the main protocols and guidelines they'd expect to see from an anticoagulation service in an institution. We know that transitions of care is a major area of risk around anticoagulation, particularly when patients are discharged from or admitted to hospital. And in fact, we've used this as a quality improvement plan as part of the PSERF, the new PSERF initiative within King's, to try and improve transitions of care, particularly looking at patients who are discharged on vitamin K antagonists. So there should be clearly defined common transitions of care, so what they are, where the risks are, establish clearly defined roles and responsibilities for clinicians. I think it's particularly important. Whose job is it to make sure someone's safely discharged on anticoagulation? Employ technology to help us, and develop transition of care guidelines and checklists. And then education. So educating healthcare professionals. So this is another core element of the document. Developing comprehensive educational material, making sure it's accessible, obtaining staff feedback on that material, and newsletters to keep staff up to date of developments. And then for patients, educational materials that are easily accessible in different formats for patients. So in terms of what we do at King's, just as an example of an anticoagulation stewardship programme, first thing that I'm going to cover that we do that maybe is quite innovative and not necessarily something that happens in all hospitals or in institutions, is we have an MDT ward round. And that's a consultant, registrar, pharmacist and a nurse who meet and do a ward round 3 times a week, Monday, Wednesday and Friday. We take referrals from ward teams. They refer for initiation of anticoagulation. They refer complex patients that are bleeding. We then go and counsel patients on the ward, and we provide perioperative advice. Anything really that's difficult to manage, the ward teams have a sort of official place to refer these patients. We also provide pharmacist-led anticoagulation clinics. So all patients are referred to the pharmacist-led anticoagulation clinic on discharge. And we also see patients for initiation who are referred by GPs or by other teams within the hospital. We check patients are tolerating anticoagulation, we counsel them, we check appropriate dosing, and we check that they're appropriately monitored within that clinic. We have a very comprehensive list of anticoagulation guidelines, probably more than most clinical areas in the hospital, and they're easily accessible on an anticoagulation intranet page. The PERT team, which Karen is going to talk about more, but that this exists to aid decisions around management of PE and the use of thrombolysis. That's part of an anticoagulation stewardship that we provide. We have an anticoagulation safety group that reports into the main medication safety group, and we monitor incidents. We look at providing quality improvement plans to improve safety with anticoagulation across the trust. We provide healthcare professional education regularly. All junior doctors get anticoagulation induction session. And then we provide regular education to pharmacists and nurses as well. And we provide in-house patient information leaflets for all patients to start anticoagulation. And most patients will get seen by a specialist anticoagulation pharmacist or nurse when they're initiated on anticoagulation, so they get proper counselling before they're discharged by a specialist. We do a lot of primary care liaison, so we have a specialist anticoagulation group with the local NHS trusts and primary care to look at pathways and guidelines and also to collaborate on safe transitions of care. And we've recently got a new post for a primary care liaison pharmacist who will work with the primary care pharmacists to look at their anticoagulated patients and implement safe monitoring and dosing, and also upskill primary care pharmacists in helping them to improve their skills in managing anticoagulated patients. Just in terms of a specific project, we looked at heparin infusions because we'd had quite a few incidents with quite serious incidents with heparin infusions. We set up a task and finish group. We audited our use of heparin infusions. We changed our monitoring guidelines. We've re-audited. We provided a lot of education. A lot of this was around rewriting protocols to try and reduce the use of heparin infusions across the trust and thereby reduce the risk associated with them. So that's been really successful. We also did have a heparin watcher where the pharmacy team were sent a list of all the patients in the hospital on a heparin infusion daily, and we would then review those infusions with a view to trying to find an alternative therapy if possible, so to reduce the inappropriate use of heparin infusions. This was before we changed to a different electronic system, so we will try to implement that again in the future. And then lastly, although this is by no means an exhaustive list of the activities we do around anticoagulation stewardship, but lastly, transitions of care, which I have touched on already. We provide guidelines on how to discharge patients on anticoagulation, and our anticoagulation nurses are very involved in the discharge of patients. So before they go home, they will be especially warfarin patients dosed for discharge, and appropriate follow-on monitoring will already be arranged, which definitely reduces the risk. In terms of further afield in other countries, examples of stewardship programs. So in Montreal, in the Jewish General Hospital, they basically implemented a project where a pharmacist was employed to look at all patients prescribed anticoagulants. So they had a daily list of all patients prescribed anticoagulation, and they reviewed them daily, made recommendations. And also interestingly, they looked at patients with anticoagulants in the medication history, but where the anticoagulation was currently held, which I think is quite interesting and useful project, because you're picking up where anticoagulation hasn't been reviewed potentially. The most common intervention from this project was dosage adjustment and drug interaction advice. And then another example from the University of New Mexico Hospital, they identified all patients on concurrent antiplatelet therapy with anticoagulation. They reviewed them and showed a reduction in inappropriate prescribing. So there's just some examples of some international programs, but there are plenty more. So in summary, the ultimate aim of anticoagulation stewardship is to reduce adverse drug errors, obviously associated with anticoagulation. This really is the day-to-day role of the anticoagulation team, but I realise this isn't necessarily standardised across all institutions in terms of access to anticoagulation specialists. The concept and the associated publications provide a really useful framework for developing anticoagulation stewardship. Are there any questions about anticoagulation stewardship?
Thanks, Ros. There are a couple of questions maybe I can put to you. Stefan, hi, Ros. Thanks for this amazing work and presentation. Seeing your links with primary care, to which group, if any, do you present this work at the ICB level?
We don't officially present this work, but we liaise with the ICB, with the medicines optimization pharmacists generally. So with that group, and yes, I mean, we will work when we we haven't done the project yet with the primary care liaison, but when we do that, we will then present that back to that group of the medicines optimization pharmacists. And we will work with them throughout the entire project as well.
And you mentioned the primary care liaison pharmacist role as well, created for that.
Yeah.
And Stefan also adds that do foundation pharmacists take part in the group? If yes, for how long?
In the group, what within the anticoagulation team?
Yeah.
No, actually they don't. They do come for visits to shadow us, but only for a short time. We have a band 7 rotation that comes to anticoagulation.
Yeah.
We don't actually have foundation pharmacists with us.
Thanks. And there's another question about how can the wider MDT be more involved with anticoagulant stewards, like the specialist nurses in stroke or heart failure? How can it link to the pharmacist?
We do have specialist nurses involved in our anticoagulation safety group, which has been really useful, and certainly will involve teams if we're working on a particular project. We'll involve teams, like we will involve ED in some of our projects in improving anticoagulation safety in ED. Because we go to the wards with the MDT, sort of unofficially, we are much more visible, and clinical nurse specialists and pharmacists are much more likely to contact us for advice because they know we exist as a team that can be contacted for advice. But I mean, in terms of more sort of official involvement of CNSs, sometimes they're welcome to come and visit the team and see what we do. And we get them involved in projects when they need to be involved in projects for particular areas. Yeah. That's generally how we do it.
Yeah, thanks, Ross. Certainly in my experience, this multi-professional interactions involved in this anticoagulation stewardship is absolutely amazing. And I think there's no doubt has hugely improved the care of patients, as well as, it's made the anticoagulation business a lot safer. And certainly, I think it's great fun to work across the disciplines and for people to bring different knowledge and skill sets into, what is potentially a very dangerous area. Anticoagulants, they still constitute, I think, the #1 patient safety and medication safety theme. So I think last question to you, Ross, is how does this fit in with PSERF?
Well, we've just started looking at PSERF. So this is patient safety incident response framework. So this is more focus less on root cause analysis for individual incidents and more on a kind of looking at the common causes of incidents, because most incidents are caused by a small number of causes, I guess. I think for us, this is really involved in the anticoag safety group. So looking at the incidents that get recorded, we really know what causes the problems. I think that's the idea or the issue. We know what causes the problems. We need to try and implement quality improvement plans to improve those things. And our current quality improvement plan, I think the key is to focus on one area for a couple of areas, but not try and do everything at once. And ours is to look at transitions of care. So specifically, we're looking at patients discharged on vitamin K antagonists, which is an area of quite high risk, even though there are less patients on warfarin. We still get quite a few incidents around that. And also the use of anticoagulation or initiation of anticoagulation in our emergency department, which has caused a few incidents as well. So they're the areas we're touching on. So that's kind of how it fits in.
Thanks, Ross. Thanks for an excellent presentation. Now, time to move on to the next presentation on DVT management and primary care. If you can kindly stop sharing, Ross, then it's a pleasure to welcome Dr. Matt Fay, who is a GP with a special interest in cardiovascular health. He's been a key primary care lead involved in cardiovascular service redesign, including the redesign of the Bradford VTE pathway. Welcome, Matt, over to you.
Thank you very much, and thank you for the invitation to present. This is my second presentation of the day, and I do apologise immediately for some duplication. It's difficult to talk about VTE twice in one day without a few slides looking very similar. So quickly, my declarations, there's very few. So VTE is significant. How do you engage general practice in a conversation about medicine? Now, I can already hear all my secondary care colleagues out in the audience saying you pay them, and money is important to general practice, and I think that's a fair comment. The other thing that we're very interested in is our time management and also our complaints. No GP wants to think that they've done something that brought a patient to harm. Now, we know VTE does cause harm, and part of the reason for that is because it can be very difficult to actually identify which of the patients you see in your on-call day as a GP may have VTE issues. As a practicing GP, when I'm on call, I'll probably take 50 to 70 calls within a working day. There's quite a high turnover, and of course our patients don't tend to spread themselves evenly through the day, so we have gluts, and you do worry that in those times when you're busy and trying to move forward very quickly, you may miss things. And with VTE, some of this can be so subtle, it can be easily missed. So how do we identify somebody with VTE? And the answer, of course, is that you have to think that it's possibly the diagnosis. So the first thing in all pathways of care, when you read anything in NICE, it's you've made a diagnosis and this is what you're going to do next. And DVT is absolutely no different. If you don't think that it could be the diagnosis, then it's unlikely that you're going to just blunder across it. The other problem we have, of course, is that patients aren't that aware of VTE as an issue, or they're very aware of VTE as an issue, either because it's happened to them or it's happened to somebody they know, and that is absolutely the focus of their concern. So how do we manage to work this through? And of course, the answer to that is that we need to look to the symptoms and signs. And this is where we start immediately to get into problems. Swelling of legs, very, very common presentation in general practice, particularly now that we've become so aggressive with our antihypertensives, trying to get the blood pressure down to very low levels. Invariably, that means that people will be on calcium channel blockers of some form, a dihydropyridine. We all know that this can cause edema. We also know that it doesn't necessarily affect both legs equally. The leg might be red. I see a lot of red legs in general practice, particularly as we get older, just through edema and dependency, causing that a bit of erythema. Pain is a really useful sign, particularly unilateral pain. So when the patient's just coming in and they're saying everything's just in one leg, it's hard to say that, well, that's probably just arthritis. It's just you've only worn out one leg rather than the two. So you've got to take a detailed history. But behind that has to be a consideration of risk. So if you're taking a history of somebody with unilateral leg pain and you know they've had a previous thrombosis, it immediately is going to heighten your concern that this may be a repeat attendance. So really important that we're talking to GPs about not just symptoms and signs, but what is the holistic view of this patient? Is this somebody who is naturally at risk of thrombotic disease? And you do wonder if we could actually build triggers into our clinical systems in general practice, that when you're on call could have a look at a list like this and say this person has multiple thrombosis risk factors. So when you're seeing them for a bit of breathlessness or pain in the leg, just heighten that concern that this might be a thrombotic episode. Of course, not all the risk factors are permanent. So what about these symptoms and signs? Well, the symptoms aren't great. Leg pain, there's lots of different causes. And then leg swelling. And we've all taught, you measure down from the tibial tuberosity and go around the calf. We've all nicked our mothers sewing tailored tape measures so that we can get a reasonable measurement. But actually, when you look into the data of that swollen leg, you start finding that actually it becomes a good way of differentiating if you've taken a good history. So we're back again to the fact that we need to consider the overall thrombotic risk of the patient and not just the symptoms and signs. So when we look again at the symptoms, what I like in general practice is something that tells me it definitely is something or it definitely isn't something. And again, we can't find that in DVT. Everything is a bit non-specific, and nothing is a strong rule out in the clinical signs. And so as soon as I've thought of thrombosis, I'm probably into a situation where I have to think about investigation. And what investigation should that be? We're just going to talk about DVT, so I'm not going to go off into the realms of ECGs, etc. And of course, what we should then think of is, how am I going to image the patient? Or if I even have to image the patient. And of course, that's where we get to the Wells score. So the Wells score helps us not to tell us who does or doesn't have a DVT. Now, I'm sorry to say that within my branch of the profession, the Wells score is being abused along those lines. And so we're just doing, Thrombosis UK is involved in a national audit looking at how GPs might be using the Wells score inappropriately, to say if you've got a score of 1 or lower, then you haven't got a DVT. And therefore we go off into a different direction. Where of course, when we look to the NICE guidance, NICE is very, very clear that actually, if you think somebody's got a thrombosis, then you need to do a test. And that test is either going to be imaging, or if they're low risk, so you do their Wells score and they have a score of 1 or lower, then actually we need to do a different test. And that test, as determined by NICE, is the D dimer. And we all have the D dimer cutoff. But of course, we know that D dimer isn't perfect. We know that we have an increased level of D dimer naturally as we age. So could we take that into account to see if we can actually determine just exactly who we're going to be sending on for scans if they have a low Wells score? And of course, we look to adjust, and of course, this is a PE paper. And what we find is that they suggest that we can age adjust our D dimer, and we know that in various areas of the country their DVT pathways do take age into account, where in other areas they have an absolute cut-off level. But this would just refine our pathway even further to reduce the inappropriate use of scanning, which of course is a limited resource. If we put too many people through this system, then we're going to end up making waits, and the longer people wait, the more likely they're going to be on an anticoagulant, possibly unnecessarily if they end up with a negative test. And so it's important that we actually consider how we use our services, and that might involve age-adjusted D dimer. What was the Bradford solution? And I brought this about just shortly after the Einstein paper published, where we essentially implemented the Einstein guidance. A little bit of support for our GPs in how to do the Wells score, who we shouldn't be including into this study, into this pathway. So they were very, very clear about what they should do. And then we made the referral form the request for the ultrasound. So ultimately, our fantastic providers, Bradford hospitals, would just do the scan in line with the pathway. Those people who had a thrombosis confirmed would be handed over to Simon Aykroyd's team so that they could have counselling and support about what to do with the ongoing issues around their anticoagulation, and of course, duration and how we should consider the dose of that anticoagulant into the future. If we look to the NHS, they have common symptoms and signs published on their website, but of course, this isn't how people necessarily will access the medical information. So although this is great, this is NHS resolutions information, but this is great, but we need to make sure people like Google are getting it right, because Google talk a lot about swollen legs, a lot about red swollen legs, and of course that's not necessarily in line with the evidence base. So you have your GP, they've seen somebody, they've assessed their thrombotic risk, they've put them onto a pathway of care as appropriate. If actually they think, well, in probability, actually I'm going to ignore the wells, I'm going to suggest to this person that actually they need a course of antibiotic for possible cellulitis, let's say. What is important that we make sure our primary care colleagues are doing? And that's safety netting. We all make mistakes. We can all get clinical diagnosis wrong. And it's even worse in an area where we haven't got such clearly defining symptoms and signs to help us decide which way to go. So it's really important that anybody who comes in with chest symptoms or leg symptoms, you've considered that thrombosis as a possibility. You may have dismissed it at this stage, but make sure the patient has information. But then coming a little bit back to what Ross has just talked about, we need to also make sure that our care for DVT doesn't stop just with this diagnosis. DOACs are not for life like statins. We can't just start them and ignore them. Although whenever you do audits on DOAC use in primary care, you tend to find people who are just loitering in the system on a DOAC, and you do wonder why. Also, it's really important to make sure that in the medicine notes in primary care, we've highlighted the reason for the patient to be on a DOAC. Because we've had a situation in my practice where somebody's DOAC was discontinued, where actually they presented with a DVT and somebody we didn't see very often, and they were incidentally found to have developed atrial fibrillation. So they actually were on anticoagulant for two reasons. And although the thrombosis period may have passed, their AF risk had remained, but they had their anticoagulant discontinued, and then unfortunately went on to have a TIA that came back to the practice to say, why did you discontinue their anticoagulant? And quite rightly so. But in the other patients, it's really important that we've got a stop date. So somebody has considered where this person sits in their ongoing risk for thrombosis. They've had a transient increased risk of thrombosis, and so they only need a transient period of anticoagulation. So it's important to make sure that's discussed as well. This does raise another issue that I just put out there for discussion, which is who decides on the duration of anticoagulation? Because we can find that people are seen on the MAU, they have a diagnosis made, and they're discharged. And actually, when you go through the records, you can't find that they've had a discussion about the potential ongoing risk of thrombosis. Is there a stop date, and is that stop date actually appropriate for somebody who may have had an unprovoked episode of thrombosis? Is it okay for a GP to have that conversation and determine the dose, or do we feel that that's something that always has to return to our colleagues in secondary care for that expert view? The other thing about thrombosis as well, of course, is that once you've had one episode, it may have been provoked. But once you've had an episode, it's really important to make sure the medical record is flagged, so that if that person goes into hospital for a procedure or attends back into general practice in several years' time with symptoms again consistent with possible thrombosis, we've got that flag to say that we know that this is a person who is at risk of thrombosis, and therefore may change our overall assessment. So in summary, there's still not great education to general practice. I made a plea to my colleagues out there in the audience to take on clinical leadership in the area of thrombosis and lead the GPs to the promised land as regards thrombosis. We need clinical leadership to push this forward. If you don't think about thrombosis as a diagnosis, you are more likely to miss it. We need to maintain that discussion over time, and we need to think about how we use our risk scores, how we use D-dimer and the immediacy of the result that we require from D-dimer, and also caution of its abuse in a tick box mentality when we don't know what the diagnosis is. But try and keep our pathway simple, and always communicate what you're doing to the patient so they can be supported and understand. Thank you very much for your time.
Thanks, Matt. You have always been a leader in the field. And similarly, there are other primary care models like in Bristol, and there's one in Essex. But I mean, most of this knowledge, we've known about for over a decade, if not two. Then why, are we still in a position where, primary care doesn't have more of an enthusiasm for this, and why, there's so many delays in diagnosis, as witnessed by the NHS resolution work?
I think that's a really important point, Rupert, that, if you consider that when we look at scanning rates, for every DVT that Bradford identifies, it scans 10 patients. Now, that's quite a low conversion rate, but you could also argue that's a lot of people coming through general practice with thrombosis as a possibility, and we're still missing the diagnosis. So we're probably not even scanning the right people. But if we actually could open that conversation with general practice about the fact that this is also about good work time management and making sure that you're flagging the right people who you really do need to put that little bit more time in, but actually, by doing a quick assessment of their thrombotic risk, etc., you may actually move people in a different direction so they don't come back with repeated appointments, and help them understand that actually getting it right first time actually reduces your workloads. And we definitely saw that in Bradford by making a simple pathway that the GPs could do easily. We did see that we started to actually see a fall in our CTPA positives. So we did see a consequence into our population.
So there are a few questions and comments. So one is, how much of an issue is follow-up after 6 months for the kind of duration discussion, and dose adjustments for DOACs in primary care?
I think that the follow-up is really, really important. I mean, I think, it's important to make sure that the most junior member of our ED team hasn't made what can be a life-changing decision for a patient. The patient needs to be appropriately counselled about their ongoing risk of thrombosis and make sure that they're on the right medication. And of course, with the DOACs, that's not just you're on a DOAC, that's what dose of the DOAC are you on. As we know, there are multiple doses that people could receive. So making sure that they've been assessed by somebody who actually understands thrombosis in the hospital, not just how to read a scan, I think is really important. The fact that the patient's been counselled so they understand why they're on an anticoagulant, they understand how to take that anticoagulant, they understand what to look out for when it's going wrong, is really important, and who's doing that. And I think that the duration question, I've seen multiple people, including one of my own colleagues in general practice, who had an unprovoked PE and wasn't aware that ongoing anticoagulation would be of value to them because nobody had that conversation with them. So it's important that we talk to our patients.
Yeah, I think Hugh in Plymouth makes those comments, even after discharge, you need bloods for renal function, never sure. This is always checked. And Hugh also says that in Plymouth, DVT pickup is about 11% of scans, though the nurse-led clinics are 18%. So I think a lot of this is down to resource, isn't it? Does the GP in that 10-minute slot, are they really able to, do this justice?
I think that the Plymouth results are interesting, particularly since they show similar to what we saw in Bradford, that around about 10%. If you looked at ED and you just pulled, because we all use the same pathway in Bradford, and if you looked at ED, that got down to about 6%. So there was still a significant overlap into the people who had scans which proved to be negative. Of course, we only do proximal leg scans, so that means distal thrombosis may have been overlooked, and the patient may have had a thrombosis, just not in the proximal leg. But if we then looked at our consultant colleagues in the orthopaedic department, they had they had 25. 1 in 25 positive. So just being a consultant in secondary care with possibly a longer appointment doesn't necessarily mean you're better at thrombosis identification.
Yeah, though interestingly, the national mortality data that we are publishing in BMJ this week shows that only 5% of the deaths were linked to elective procedures. Most of them were linked to being admitted to hospital with pneumonia or medical diagnosis and then dying within 30 days of that episode. So again, I think there's a big piece of education to be done, both in secondary care and primary care, just as you said, to think thrombosis,
Yeah.
If someone has just been in hospital with a pneumonia or myocardial infarction, to think thrombosis if they have those symptoms.
And pregnancy and acute injuries and what is their body shape, what's their smoking habit. Make sure you keep thinking that people's risk varies with time and age.
Thanks, Matt. We could go on, but time is pressing. Thank you so much. You really are a legend. So, which then, talking of legends, brings me to Karen Breen, who's really one of the leading thrombosis hematologists. She's based at Guy's in St. Thomas's, where she's done a lot of pioneering work in this area. So, which includes what she's going to be talking about, which is the pulmonary embolism response team, which really has changed the paradigm of how we manage high-risk PE. Over to you, Karen.
Thank you very much, Roopen, and thank you for the kind introduction and for having me today. So I'm hoping you can all see this. So today I'm going to talk about the role of PERT, or PE response teams, in PE management. So just, I suppose, a reminder, first of all, about how PE can present in many different ways. So of course, with the advent of better imaging and patients undergoing lots of scans, for example, during their cancer staging imaging, often you'll have patients who have a diagnosis of incidental PE. So those are patients who are asymptomatic. When you press them for symptoms, often they don't really ever know that they could have had a PE. So they're pretty asymptomatic. Then you have patients who have what we would classify as a more standard PE. So they do often have symptoms, be it chest pain, hemoptysis, shortness of breath, but they're usually not cardiovascularly compromised. And when you calculate their PESI score, so their PE severity index score, often that's low. So these are the types of patients who have segmental PEs, don't have a significant clot burden on their scan, and can often be managed as an outpatient with anticoagulation alone. But for the purposes of today's discussion, really the kind of cohort that we're focusing on are those patients who have what we call submassive PE or massive PE. So they're the unstable patients who are cardiovascularly compromised and unwell because of their PE presentation. So this is a diagram taken from the European Society of Cardiology guidelines in terms of how we classify PE. So we're really talking about these patients who are sort of in the red row across, who have high risk PE, so they're unstable. Often they've presented with hemodynamic collapse. They've got a low blood pressure, they've got a high PESI score, elevated troponin, and if you're lucky enough to get an echo, they've got signs of right ventricular dysfunction on echo, or at least on their CTPA. And then you've got this cohort, the intermediate risk patients. So if you classify those patients into sort of intermediate high and intermediate low risk, the intermediate high risk patients are those patients who might be on a small amount of oxygen. They're, maybe they've tachycardia, sometimes they might drop their blood pressure, they've got an elevated troponin, and they will have signs of right ventricular dysfunction on their CTPA, and again, if they've had an echo. So they're the particular cohort that have an increased risk of morbidity and mortality. And in recent years, there have been lots of different options in terms of how we manage these patients. So as well as having standard therapy of anticoagulation alone, we've now got all of these new shiny devices, including catheter-directed thrombolysis, ultrasound-guided thromboaspiration, suction devices. And for the really unwell patients, you have the option of using ECMO or surgical embolectomy. But suffice to say, it's not a one-size-fits-all. And of course, we also have the option of giving those patients who present to an institution who don't have access to these new interventional radiology-based options of giving half-dose systemic lysis. So it's for those patients who have intermediate high-risk PE and whom you're concerned are unstable, but you're concerned also equally about bleeding risk. So that's why the PITHO trials and other publications have showed evidence for a sort of half dose of TPA, so a 10 milligram bolus followed by a 40 milligram infusion. So they're getting an overall half dose compared to those patients who have massive PE who need to have full dose thrombolysis when they present. And in a way, they're almost easier to treat because you know that if you don't treat them, they've got a really, really high risk of morbidity and mortality. So why do we need to intervene for these patients with submassive PE? So theoretically, the rationale behind using these options is that you improve pulmonary perfusion and right ventricular function, you reduce the clot burden and acute pulmonary hypertension in these patients. But by using either half-dose systemic lysis in these patients, you're lowering the risk of hemorrhage. But now with the advent of these catheter-based therapies and thrombectomy devices, actually the dose of lytic that you need to use with these devices is lower and lower. And in some cases, you barely even use any. But suffice to say, the data is not fully there yet. So I think it's really important to say that we need to consider restricting intervention to those patients whom we consider to be at the highest risk of morbidity and mortality. So at the moment, in terms of guidance, this is just one example that we have here with NICE guidance, and what NICE say in terms of patients who present with hemodynamic instability that we consider thrombolytic therapy, and similarly lots of other international guidelines such as ESC, CHEST, etc., all discuss sort of consideration of thrombolysis, but there's no real sort of definitive recommendation to go ahead and use this. And then more recently, some of you may be aware about the update in the publications from NICE in terms of what we need to do for patients who may need to be considered for thrombectomy. But really, I think they're advising us that we have to really consider only using them when we've got no other options. So alternative treatments have failed, or it's in the setting of research-based criteria. So suffice to say that we have to really consider who we should use these options in. So getting to the main reason that we're here today is to discuss PERT teams or PE response teams. And really, they've been around about 10 years, first developed mainly in the US, and they were developed to coordinate and expedite diagnosis and treatment of PE. And I think really considering that we have all of these options, it's important to involve a multidisciplinary team to help make decisions when it comes to managing these patients, because often, teams who are not used to the consideration of using these devices don't know who should have the option of thrombolysis, which patients should be treated, and what's the best option. So I think it's really important to gather a group of experts who are used to managing PE to consider who is best placed to use these different types of treatments. There has been some data since the PERT teams have been developed to show that it improves time to PE diagnosis, initiation of therapy, so be it just anticoagulation or whether or not they have an additional treatment. And there's also some evidence to suggest that there's therefore a decreased length of stay, the cost of care is subsequently decreased, and there's possibly even an improvement in mortality. So there have been some recommendations that if you've got the appropriate resources and expertise, you should try to consider setting up a PERT team in your locality if that's possible. It's still a developing phenomenon, suffice to say. So this is just a publication from Rachel Rosovsky and her team in Boston, who worked alongside us to talk about PERT development. And you can see here that obviously there's been a lot of PERT team development in Canada and US. And of course, that's probably partly financially driven, but also in Europe, you can see that the PERT team concept has been developing increasingly over time. Here at GSTT, we've developed a PERT team probably also about 8-9 years ago, and we've been trying to provide a standard of care to patients. So if you present with a PE, regardless of which team you're under, you get the same standard of care, and I think that's really important. We're made up of a multidisciplinary team of interventional radiologists, us hematologists as gatekeepers, respiratory clinicians, cardiologists, critical care, and obstetrics when you've got a pregnant patient involved. We've really seen quite an increasing number of referrals over the few years that we've developed the PERT team at GSTT, and I know Roopen and his team at King's have also developed a PERT team recently, as well as some other centres around the UK. So what happens when we hear about a patient? So the PERT team are activated. The diagram on your right is an example of our app called Pando, which is acceptable for use within the NHS. It's secure, so we can use patient data on there to communicate to the rest of the MDT. So we have an activation using Pando to let us know that there's a patient who needs discussion. Whoever is around, we'll try and go and see them to assess them clinically and make sure that they meet the criteria for at least intermediate high risk PE. We'll try and get echo, Dopplers, assess their bleeding risk, and then we'll have an MDT discussion as to whether or not they need thrombolysis and what's the most suitable option for that patient, be it systemic or be it an interventional radiology procedure. But suffice to say, it's really important you involve patients in any decision making when the data is not fully there, what the risks are involved, and often sometimes less is more. So sometimes we'll just serially assess the patient, see how they're progressing if we don't feel they need to have anything done urgently. So it's important to say that you don't necessarily always have to intervene in these patients, and some of them often do well enough with anticoagulation alone. Our experience so far has been, that we've been seeing quite a lot of referrals, particularly from external centres. We have, within the trust, seen that most patients who present with PE are usually referred to us within the first day of diagnosis of their PE, and that initially we also saw there was a trend to lower cases of patients who may have CTEPH, for those patients who had an intervention, and possibly also a trend to a shorter length of stay. But increasingly in recent months, and certainly in the last 12 to 24 months or so, we've been referred increasingly complex cases. They've often been referred to us, several days after their presentation to a local hospital. So by the time they come to us, they can be really quite unwell. So this just shows you an example of the increasing number of referrals that we've seen over the last few years. These are the different types of interventions. So you can see here, that there's around about 40% of patients who don't have any intervention. And these are the different types of interventions that patients have received in the last few years. Some institutions might consider this quite low, but I think because of the nature of the number of referrals we receive externally, often those patients really do need an intervention. So that really has skewed our data, I think, in terms of how many patients have had an intervention. This is just a pattern of the different types of interventions the patients have had. So the red line is the catheter-directed thrombolysis. These are thrombectomy, and this is a combination of both. Challenges to date, I think so far, sometimes it can be quite difficult to prove to teams the sort of rationale behind the use of a PE team. And there's still a lot of clinicians that require convincing in terms of the role of catheter-based devices for the management of PE. who owns the service, who triages the calls, and certainly my hematology colleagues here at GSTT often, I'm not their number one on their Christmas card list when it comes to being on call with the PERT service. So needless to say, I think the pathways definitely need refining. We need to make sure patients are being referred appropriately. Often we'll get cases who are very low risk standard PE, and then funding, of course, who's going to pay for all of this. So future directions, I think it's really important that we get PE management correct. You know, often patients don't even have a troponin when they present. So just even trying to categorize patients' risk. We need to make sure that these reperfusion options are being used in the right hands. We need to optimize PERT services going forward, and where possible, establish PERT networks. And then finally, just to say, who knows where the role of AI will take us in how we manage PE patients in the future. So with that, conscious of time, I will take any questions. Thank you.
Thanks, Karen. Brilliant talk. And really, I think you've done some pioneering work in this area. There's a couple of questions. The first is, what is the role of echo and troponin in a frail patient with a high PESI score and submassive PE? And no hemodynamic stability, not for thrombolysis. Does it not just prolong length of stay?
That's a really good question. So I think it will certainly help us manage those patients and classify their risk, because those patients have potential. And by that, I mean they have potential to become really unwell really quickly. So if you have a patient who, yes, albeit maybe frail, but who have had a really good, or sort of albeit at least a decent quality of life before their admission, you may consider using some sort of intervention-based therapy with really low dose lytic if you feel that's appropriate in that patient. Otherwise, you know, I think you have to use the data to decide when it's safe to discharge that patient.
Yep, thanks. The other question is, what are the criteria for PERT activation? Is it all intermediate high-risk cases? Does it get activated out of hours overnight? Is it voluntary on call? Depends how you define
Very controversial questions. So we can really only provide the service in hours. And I think that's probably reflective of how a lot of other services operate. There's this sort of semi-PERT team on call out of hours. So by that, I mean us as a thrombosis team on call take some calls and then speak to our interventional radiology colleagues to look at images and try and decide if it's appropriate. But I think, like I said, a lot of these patients you will find as you get used to managing them don't need anything done overnight. And that's a really important thing to say, is make sure they're stable on anticoagulation overnight, and then use whichever parameters you have to try and predict what risk they might have. But technically, the patients who should be referred are those patients who are intermediate high risk PE. But I'm sure, Roopen, as you'll testify, quite often we get all sorts, all comers of patients referred, and they're quite often low risk PE. And you've got, coming back to Matthew's points, you know, a junior doctor who's not used to managing patients with PE and simply don't know what to do with the patient.
Yeah, sometimes I think we are just in the business of educating the junior doctors whose consultant has asked them to trigger a PERT call. But I think overall, sort of our experience, certainly it's very onerous, but I have no doubt that it does give the patient, you know, a better quality of care and more options. And then for me, a question arises about equity of access, you know, that if you're in hospital A, you've got these 5 options. If you're hospital B, you've got 1 option.
Yeah.
So I think that is something to be worked on. And, you know, we don't often get the interventional people to do stuff, but they do. And last week we had a surgical thrombectomy, which was, you know, was not something that happens every day.
Yeah.
So thank you. Very, very interesting talk. I'm aware of time. And, just lastly, I'd like to thank all the three speakers in this afternoon session, all brilliant and all leaders in their field, and certainly lots of food for thought. And, thank you to the over 300 attendees who have listened this afternoon. And last but not least, thank you to Thrombosis UK and the wonderful Joe Jerome, who is continuing with our unstinting efforts to promote thrombosis care in the UK. So thank you all. It's 2:00, time to let you go.